All right, Professor Klein back here with you, coming from the physical therapy clinic. And today we are talking about the back and the shoulder. And with the back and the shoulder, it's all about muscles, muscles, muscles. Lots of muscles to teach you guys and to talk about how to strengthen them, how to rehab them, and how to keep your clients healthy. I'm excited. Hope you're excited. Let's jump right into it. First up, quick reminder that if you don't know the vertebral column, go back to the previous PowerPoint and learn the vertebral column and all the bony landmarks. A lot of the back and shoulder muscles attach to these bony landmarks, so you gotta know them well. Here you can see on this slide a few different regions of the shoulder, and it breaks it down into pectoral, it breaks it down into scapular, lateral supraclavicular, deltoid, many different regions, axillary in there as well. So review these body regions as well. But really, as we start to look at the shoulder and the back, these are a lot of muscles that we can palpate. And on your patients, on your clients, you will have to palpate these things. So it's good to start with palpating yourself, feeling things like the clavicle. Go ahead, feel your own clavicle. Common name is the collarbone, but you gotta call it the clavicle. Here's one clavicle that I've got taken out of a body. And if you look here, you'll notice there's a flat side, there's a rounded side. That rounded side is gonna go over towards the lateral part of the shoulder. The flat side is towards the sternum. So when you're feeling that, you are feeling these actual bony landmarks on the clavicle. And if you go far enough, you'll actually jump off of the clavicle and you'll come up to the scapula. So the scapula, we know it has this bony landmark way out at the side called the acromion process. Go ahead and feel your acromion process as the most lateral bump on your shoulder. And that acromion process is part of the spine of the scapula. So take a second to walk your fingers back down that spine towards the back. Now on here, you can see that acromion process as labeled right here, and then walking it down the spine of the scapula. Now the green part, you can also palpate. You can feel the inferior angle of the scapula, the medial border, lots of different things, and maybe try this on someone else as well to learn these palpation skills. Now we know the humerus, funniest bone in the body, the humerus actually connects to that scapula. So be able to feel the acromion process, but then drop down about an inch inferiorly, and you can feel the greater tubercle of the humeral head of the humerus. All right, enough palpation. This is not massage class. This is class to learn more about the rib cage as well. So the rib cage is definitely part of the back and the shoulder. So review the rib cage if you have not done so already. Multiple perspectives here. So you can see it as a skeleton, you can see it as an x-ray, and then you can see it on an actual individual who is performing a maneuver that would really highlight the rib cage itself. So notice the different divisions for the ribs as it comes up to the shoulder, chest, and back. So let's zoom into some of these things. First, that clavicle. So the clavicle, like I said, it's got a rounded end, it's got a flat end, and the flat end, as we can see here, is called the sternal end. It's flat, it's going up against the sternum. What part of the sternum, you ask? Well, specifically the manubrium. Definitely know that word, know how to spell it. Manubrium, I'll outline it for you as well. That's that top part of the sternum, but the sternum also travels all the way down here with the body and then the xiphoid process. So that's the whole part of the sternum, and we know the sternal angle of, or sternal end of the clavicle attaches to the manubrium. But don't forget the other rounded end, that's the acromial end, because it's going to the acromion process of the shoulder. Down below we can see clavicles protruding out of someone's skin, and really seeing these bones prominently on top of the rib cage. So that was the clavicle. This is the humerus. The humerus, humerus is this bone right here. It's got the top part, which is the head of the humerus with different tubercles, and I'll allude to these pictures here, but it also has a bottom part that makes the elbow bone. So if I'm holding this humerus up to my arm, notice how the bottom part goes into my elbow, top part is the shoulder. And everything on this slide you want to know. So there's a lot of bony attachments to here. Deltoid tuberosity. Later when we look at the deltoids, that's where the deltoids insert. The greater tubercle, rotator cuff muscles attached there. And the head of the humerus going into the scapular cavity as well, so the glenoid cavity. But down below we can see some special words like the trochlea. I'm going to outline the entire trochlea. As you can see it highlighted in this picture. The trochlea is an attachment point for the ulna. The capitulum, more ball-shaped, is an attachment point for the radius. So we'll get to the elbow and the arm later, but for now, definitely know all these anatomical landmarks. Did the clavicle, did the humerus, now we're on to the scapula. And with the scapula, make sure you're looking at an anterior or a posterior view. This right here is anterior. I can tell that because the choroid process is facing me. The choroid process is this bump, and that bump is always anterior. Now, posteriorly, over here, you can always see the spine of the scapula. Remember that bony spine that you felt in your back? That's pointing backwards or posteriorly, and it leads all the way out to the acromion process. Acromion process, notice, attaches to the acromial end of the clavicle. And I want you to start to think about what are some of the qualities of the glenohumeral joint, which is the joint of the humerus and the scapula coming together. What are some of the characteristics as far as mobility and stability go? What can you do with your shoulder in terms of mobility and stability? We'll talk on our professional teams more about that. Mentioning a few other things on the scapula, you've got a superior angle, an inferior angle. This one's really important for movement, so definitely know the inferior, medial border, lateral border. But then you've got all these different fossas. The scapula has a lot of different fossas. What's a fossa? It's a nice smooth surface. So muscles will attach there, but definitely know the different fossas. And a lot of times the fossas will tell you what muscles attach there. For example, the supraspinatus fossa has a muscle called the supraspinatus muscle that attaches right on that fossa. So learn the bones, learn the bony landmarks, and the muscles will be a lot easier. Quick question for you. Take 10 seconds, but you tell me, what is this bony landmark down here? It's been highlighted. I'll even highlight it even more. anterior view on this side, posterior view on this side. 2 seconds. If you said the trochlea, you would be correct. This is the trochlea for sure. And another way that you can tell that this is the trochlea is that the trochlea is next to the medial epicondyle. Medial epicondyle. Notice how the medial epicondyle is much larger than the lateral. Feel the inside of your elbow. Yeah, go ahead and feel that inside of that elbow. Feel the medial epicondyle and you'll feel the bump. Now feel the lateral part of the elbow. It's flat, it's smooth. So the big bump is the medial epicondyle, the small bump is not. The trochlea is always next to the medial epicondyle. As we start to get the bones and the joints down, we'll talk about movements. Clavicle actually moves a little. You bring your shoulder back, go ahead and bring your shoulder back like that, and you feel the clavicle, you're gonna get a little bit of movement. We won't focus on technically what this is called or how this happens. The clavicle is just on for the ride. It's just there for the ride, oftentimes with the scapular movement. All right, let's dive in more to that glenohumeral joint, shoulder joint. I will want you to call it the glenohumeral joint for most situations. It's a ball and socket joint. It's got a membrane. To answer that question from before, it's very, very mobile. You can move your shoulder in a giant arm circle. Give it a giant arm circle wherever you're at. Careful of your surroundings. But that's awesome for the shoulder because we need to be able to move our hands, move our arms all over the place. That's the mobility we need. But with increased mobility, you have decreased stability. I've got movement, but there's not a ton of things holding it in place as compared to other joints. Think of like the skull joint. The skull joint is highly stable, but very not mobile. Flip those. The shoulder joint is highly mobile, not very stable. And that can create a lot of issues. So as you can see, this shoulder joint has a little bit of articular cartilage as it articulates with here. That's the hyaline cartilage coming in between joints. We also have a lot of labrums. You might have heard labrums before, torn labrums. These are going to cushion and support this joint even more, as well as rotator cuff muscles, which we'll look at later. Let's give you some cadaver human body donor pictures and surgical pictures here. This is the humeral head being performed or surgical procedure on during surgery. Over here we can see the entire shoulder back region with a lot of different muscles. You will see tons of muscles in pictures like this throughout this PowerPoint. Look for a couple things. Look for the striations of the muscle. You'll notice there's different muscle striations, and I'm just giving you an example of a few of these here, but notice the muscle fiber direction. That's going to be very important when we talk about how to strengthen these muscles. But before we get to muscles, let's talk about ligaments. Ligaments are bone to bone. You know the two bones? You can probably name the ligament. For example, we've got 3 main ligaments right here that deal with the shoulder area. And as always, if you don't know something, divide it in half and you can break it down into 2 different parts. If it says coraco, coraco sounds like the clavicle, but it's not the clavicle. It's actually the coracoid process. Coracoid process would be this bony landmark here. The acromial part is talking about the acromion process. Acromion process. So, in something like the coracoacromial, that means it's going from, let's label it number 1 here, the coracoid all the way up to the acromion process over here. So this black line is outlining that ligament. But number 2, acromioclavicular. Now we have acromio. We're still going from the acromion process, but now we're going straight over. Clavicular is clavicle to the clavicle. So this is the acromioclavicular or AC ligament. You hear about this one all the time in shoulder separations, and now you know it's a ligament from the acromion to the clavicle. But we're not done yet. Number 3, the corticoclavicular is down here, and corticoclavicular actually has 2 parts. You want to know both of them. First is the trapezoid part. Trapezoid part with the conoid part right here. Both parts are from the coracoid process to the clavicle. That's the corticoclavicular ligament. Number 3, know both parts and know which one's lateral, which one's medial. Those are the main 3, but there's number 4 and there's number 5. Talking about glenohumeral, coracohumeral, slice, slice. Now we can see these here as the ones that go from either the coracoid process to the humerus, or we're going from the glenoid cavity to the humerus. So anytime you see humeral, think humerus. And all these ligaments are passive stabilizers. Passive meaning you cannot contract a ligament. Ligaments don't contract, muscles do. So if ligaments cannot contract, they are passive. They are helping stabilize the joint, but since they cannot contract, they are passive stabilizers. Let's look at the shoulder from a lateral view here. So if you're looking at the scapula, turn it this way. Now you can see the glenoid cavity, this lateral view. And in that very shallow cavity, we start to see why the shoulder joint is so mobile. Largely, again, because the shallowness of the glenoid cavity, it's like going into a small cave. You've got a lot of mobility when that happens, and you have movement along pretty much all the axes, all the different axes of the planes of the body. So I can flex the shoulder, I can extend the shoulder, I can abduct or abduct the shoulder and add a deduct it back down. But not done yet. I can internally and externally rotate the shoulder. You can do so many different things with the shoulder. One last thing on this slide is the coracoacromial arch. There's an arch that forms by adding the acromion, the coracoacromial ligament, and the coracoid process together. It forms this giant arch right here across, covering or basically making a roof over the glenoid humeral joint. Let's zoom into that arch and specifically the AC joint here. This is a superior view, so we're looking at an aerial view of that joint, and we can see the clavicle, we can see the acromion, and that AC ligament coming pretty much straight across, just like a bridge would bridge these two things together. Here's another look at it up top, and then you also have more of a frontal view down here, but that AC ligament is often damaged, so make sure you know that one for sure. In addition to the AC ligament surrounding the AC joint, you also have the corticoclavicular ligament coming up here to support, actually over here, to support that AC joint. Those two are the main ones. In addition to, you keep seeing the word trapezoid and conoid here, those different parts to passively stabilize the AC joint. I'd like to take a moment to talk about the bursa. So bursa are fluid-filled sacs. So you got labrums, you've got ligaments, you've got muscles, lots of other stuff, but you also have these bursa because anytime you have a ton of stuff in one area and these things start rubbing against each other, friction causes damage. So to reduce the friction and facilitate movement, we've got the bursa, fluid-filled sacs, little squishy things in there, gel-like squishy things that will essentially cushion or protect these different things from causing friction. Pause the video for a moment and recap all that stuff. We're about to get into the back and shoulder muscles themselves, but you got to know the bones, the bony landmarks, and the ligaments, or nothing else will make sense. So take a moment, pause the video, write it out, and then come back for the muscles. All right, enough with the bad anatomy jokes. Back to the actual anatomy. And here we can see the muscles of the back. So we're looking at the axio-appendicular muscles, fancy word to say the back muscles. And we can see multiple different layers. So be careful when you look at this picture, because the most superficial posterior, that's like these muscles here. I'm going to outline the trapezius. I'm going to outline the deltoid, the latissimus dorsi down here. These are the ones that you can feel on your back, but there's ones deeper. The deep posterior, we're looking at things like the rhomboids. Here's an outline of the rhomboids. You have to peel back or remove the trapezius to get to the deeper rhomboids or the levator scapulae up top there. Over on the shoulder is that deltoid region, and then even deeper we've got the rotator cuff muscles. There's a group of them over here at the shoulder that's going to, you guessed it, rotate the shoulder. So that's kind of the broad divisions or categories of the back and the shoulder. Let's dive in. Let's first dive into the trapezius, the most superficial one here. And the first thing we're going to look at with the trapezius is it's all the way up at the skull, all the way down to about the mid-back, going straight up those spinious processes that you can feel. Then it's swinging on over, and it actually, you actually lose it because you can't see where it attaches on the clavicle. But then it pops back in, coming across the acromion, down the spine of the scapula and around to form that trapezius. It's a triangular shape. When you put it together, they call it kind of a diamond shape. But remember, there would be another one on this side as well. So imagine that trapezius. Now, the trapezius has 3 different divisions to it. So, Professor Klein, you're saying I not only have to know the name of the muscle, but the different divisions. In the case there's 3 of them. Yes, you definitely want to know all 3 divisions: 1, 2, 3, descending, middle, and ascending divisions. Now I'm going to split it into here, and really you split it with the muscle fibers. So noticing that the descending fibers, they're literally going downward from the neck. The fibers run downward, versus the middle fibers, these run straight across. And then ascending, you guessed it, we're going up. So ascending, middle, descending, those are the 3 divisions, power of 3 divisions of the trapezius. And not to further complicate things, but there's also other names for these: the upper fibers, the transverse fibers, and the lower fibers as well. Just a quick look at their actions. They pretty much all have different actions. So you could kind of think of them as 3 different muscles, even though it's one giant muscle. But let's break these down individually. Before we do that, let's look at the surface anatomy. A lot of surface anatomy pictures of weightlifters and bodybuilders, so you can really see the muscles prominently stick out of the body. Here you can see it. Oftentimes in these pictures, you'll lose it because there's other muscles that kind of come over top, such as the deltoid. But here we can see the trapezius, these muscles in here. This would be the left side. This would be the right side. I draw a dividing line down the middle for those traps. Here's a cadaver picture showing you it in purple. The more perspectives you have, the better on these muscles. And here are my summary tables from your book. Your book is great, but I've summarized it for you into the different regions of the trapezius, noting things like the upper trapezius. The insertion point is on the lateral 1/3 of the clavicle and the acromion. The origin way over in the middle of the back, right? And we're doing elevation and upward rotation. Hey, real quick update or real quick reminder of what origin and insertion means. Origin, just did a Google search here. Origin is the attachment point of the muscle that's on an immovable fixed bone. It's typically closer to the trunk, and the insertion is on the movable end that connects the other side of the muscle. So if we're looking at the biceps here, the origin would be up here at the shoulder, that coracoid process. The insertion would be down at the bottom. So when you go to contract your biceps, what happens? Your arm comes up closer to your shoulder, right? Your shoulder doesn't, I can't even do that. Your shoulder doesn't go closer to your arm. Your arm bends up. So that's why this is the insertion. This is the origin. So back to the tables, but that's just a quick update. You also want to know the nerve innervation. Luckily with all these, it's the same spinal accessory nerve. But the middle trapezius, note that it's coming off the acromion and the spine of the scapula. So now we're more towards the middle of the back. And the origins are these sections of the vertebral column. Love the middle traps because it's straight scapular retraction. Couple slides we'll talk about exactly what that is, but imagine pinching your shoulder blades together. Pinching your shoulder blades together, and that's scapular retraction. Down here in the lower traps, we're talking about the spine of the scapula, so now we're all the way over in the middle, as low as you can go, and it does depression and upward rotation. If these actions don't make sense yet, that's all right. Come back to the tables after we learn the actions. And Professor Klein moved the slides all around, so I actually jumped way down in the PowerPoint if you're following along to the scapular rotation slide, just to talk real quickly about the actions. And the actions we can see here, there's 6 of them. Let's start with elevation. Elevation is elevating your scapula on up. So notice the scapula normally would be, let's say, here and here, and they've been elevated, which is shrugging your shoulders. Go ahead, at home, wherever you're at, shrug your shoulders on up, and that's elevating your scapula. The opposite of that, number 2, depression. Depression is lowering the scapula. It's bringing them down. Now, oftentimes when you start up here and you relax, that's placing your scapula in a depressed or neutral position. The next one, number 3, they say adduction. We're going to go retraction. You see retraction so much more than adduction of the scapula. So scapular retraction is pinching your shoulder blades together. The scapula are coming in this way, and they're bringing them together for scapular retraction. Opposite of retraction is protraction. Protraction is coming out to the side here. So protraction you can do if you take your arms and you really stretch out. So notice if I had the scapula here and I went like this, it would bring them more interiorly or laterally to the sides. And that's number 4, scapular protraction. Last 2 are a little bit tricky, so I'll try to show you in the video as well as annotate it down here. First one is upward rotation. rotation, upward rotation, and I'll just tell you the last one, downward rotation as well. Upward rotation is when the inferior angle rotates laterally. So if you had the scapula, let's say I had the scapula here is on the side. This would be upward rotation. See how the inferior angle is traveling laterally? But if I go this way, this is downward rotation because the inferior angle is traveling medially. So use that as upward and downward rotation. Here you can see it in the picture as well. You can't really do a ton of downward rotation as much as you can do upward, but it is possible with a few of the muscles that we'll look at as well. And your book might say rotate superiorly or rotate inferiorly, whatever. In the PT clinic, you're going to use upward rotation. You're going to use downward rotation. That's just what professionals use most often instead of what the textbook says on that. And I'll also mention when we're talking about glenohumeral rotations, your book might say medial rotation and lateral rotation, but in the clinic, typically you'll hear internal rotation and external rotation. Talk to most PTs and they'll confirm this. All right, so you can see the origins, the insertions, the actions, the innervations, but really we want to get to how do you strengthen these muscles using the actions. So the apprentice says, how do you strengthen a specific section of a muscle that has different divisions and actions? And the sensei master answers, you must follow the fibers. So to work specific fibers of a muscle to produce that action, you want to follow the fibers and produce an action that's most parallel with those fibers. Here's what I mean. If we're looking at the trapezius and we want to look at the upper fibers, and the upper fibers travel like this, and you perform an action that lifts up the shoulders and maybe even bring them in a little bit, these arrows are traveling most in line with those upper fibers. So down here below, oops, we got a video of some shrugs. That's scapular elevation at its finest. That's going to work those upper traps specifically because it's elevation. Now, if you wanted to work more middle traps, and I'm abbreviating traps for trapezius, you definitely want to spell it out on the exam. The middle traps we know run horizontally or straight across. So what he's doing is just a straight row where he pinches his shoulder blades back. He's doing scapular rotation, not elevation, not depression, because the action of the middle traps is scapular retraction. He's following the fibers and he's doing the action with some weight to stress and contract those muscles. Now the upper and the middle traps, probably the easiest. The toughest, I would say, to focus on, but maybe the most important would be the lower or ascending fibers that do scapular retraction. We know how to do retraction, but how do you do scapular depression? Well, let's take a look at this video. So we're watching this video here. He's about to take this bar and push it down.
Straight, don't bend the elbows, is allow your shoulders to come up as high as you can. And you're going to use those lower traps to pull the handle down and pull your scapula down. Contracting the lower traps up as high as you can. Keep those arms straight as possible. Back down.
So he is pushing down to contract the lower fibers of the traps. Here you can see a great shot of it. Depression, scapular depression at its finest right here. All right, enough of the traps. We're on to the latissimus dorsi, another huge muscle in the back. And let me just show you the latissimus dorsi. You can't even see it all. It gets hidden up here in the humerus. It actually attaches to the humerus. So the latissimus dorsi, I kind of lied. It's not a back muscle, even though it takes up a majority of the back. It's actually an arm muscle because it has an action on the humerus, which is part of your arm, not part of your back. And it's inserted on the intertubercle sulcus of the humerus. Check out way back in the beginning of the PowerPoint for where that's at. Well, it also then goes over to the thoracic and thoracolumbar fascia. See all this thoracolumbar fascia? Now we know why it's so thick and it's so big. It's because we got one of the largest muscles of the body, the latissimus dorsi, connecting, originating into that thoracolumbar fascia, as well as some thoracic vertebrae. Now, what does it do? You say it does glenohumeral adduction, extension, and internal rotation. So again, it's an arm muscle because it has 3 actions on the humerus itself. We see this performed in a lat pull down exercise where he is pulling down, he's adducting, extending, maybe not internally rotating, but he's doing 2 out of the 3 actions, which will definitely work that muscle. Brought out a classic picture of one of the weightlifting legends, Arnold Schwarzenegger, and showing the latissimus dorsi coming up and around. This gives a very wide view superficially of the body. If you want to widen your torso, the latissimus dorsi is the muscle to focus on. Question for your small groups: should you go in front of the body when you're doing a lat pull down or behind the neck? Here's 2 examples of it. You guys research it. You tell me what is best for your clients. We're not done yet with the latissimus dorsi, but we got to talk about the latissimus dorsi's little brother or little sister. And in that case, the little brother, little sister of the latissimus dorsi is the teres major. So we're going to get to the teres major in a second, but just take note, it's a muscle on the shoulder back region we'll look at that does the same thing as the lats. So let's say latissimus dorsi, teres major, together they're doing that adduction, extension, and internal rotation. Now you could do a lat pull down, or you could go swimming. Swimming definitely works the latissimus dorsi and teres major. Here's Nathan Adrian pulling his hand backwards. He's adducting, he's extending, and he's internally rotating a little bit at the end. Swimmers gotta have strong latissimus dorsi and teres minors to do well. This shirtless guy looks like he has something to say about the pull-up and the latissimus dorsi, so let's take a listen.
Exercises great for the core, great for the lats, great for the whole back, but it needs to be done right in order to get a lot of the benefit from it. So we're going to cover today the very start of the pull-up. I'm talking about right before you go to pull. There's one movement here that I need you guys to focus on, so I'm going to show that to you right here.
Watch this movement.
What I'm talking about is the movement from here to here. So let myself time, I'm trying to push my chest up and out. I relax.
All right, if you saw that video where first he doesn't pull straight up, what he does is he depresses his scapula and retracts, engaging the trapezius before he even starts to pull. That focuses it on the back. And here we can see him kind of talking more about how he does that.
These are muscles that are super important for shoulder health. When I've worked with physiotherapy before, I've seen a lot of people.
All right, so thanks to that guy who said he works in a PT clinic and does a lot of YouTube videos to educate on things that they're doing in PT school. I highly suggest using YouTube to find videos just like this and apply the anatomy to things that you are interested in. So here's that teres major. Let's take a look at it. First off, it is posterior on the scapula. It is going over to the humerus. There's a teres minor as well. Teres minor is part of the rotator cuff muscles, but teres major is not. Again, put the latissimus dorsi and the teres major together. It's doing all the same things. Here's a great video, real quick GIF that keeps coming in and out. That is the action of the teres major. A quick way to remember the latissimus dorsi is a nickname for the lats is called the handcuff muscle. Because if you've been handcuffed, hopefully not, but if you have or seen it, basically it's adducting, extending, and internally rotating everything that's going on in the shoulder joint for this individual. So extension, adduction, and then internal rotation for the handcuff. So try it yourself just wherever you're at, and you can feel all three of those actions. All right, just another shot of some latissimus dorsi from the posterior, from the anterior, a couple famous people on here. And if we also look down here again at the cadaver body donor, we can see there's a multitude of sizes that the latissimus dorsi can be. So next time you're at the gym, if you don't go to the gym, highly encourage it because one, you can get a great workout in, lifting weights, building strong bones and muscles and health, all that great stuff. But you can also study at the same time now. So do a lat pull down, feel those muscles on the side. Try to tell yourself, okay, where's the origin? Where's the insertion? What's the action while you are lifting? Moving on, keeping things rolling. We're going to the anterior side. We're going to the pectoral girdle. We're talking about the pectoralis major, the chest muscle here, huge muscle on the anterior part, so huge that it actually has two different heads, clavicular and sternocostal, and three different divisions, so upper, middle, lower fibers. We'll break these down in the next few slides, but again, power of three. And just a quick look at the origins and insertions. I mean, we got clavicle action here, we've got manubrium, we got sternum, we've got costal cartilage. That's where the costal part comes from. Costal cartilage of the ribs, mainly seven, a little bit of 8 down there as well. And then we're going all the way over to insert onto the humerus. So lots of arm action with this one, but this is a pectoral girdle muscle. And if we were to draw in the deltoid, we can see there's a triangle that forms. See this triangle? This is the clavi pectoral triangle. Probably mispronounced that, but that is the triangle that's formed from in between the clavicle and the pectoral girdle. All right, let's get a full pronunciation for that so you guys are getting the correct pronunciation from this video.
In this module, we are going to discuss about the clavipectoral fascia. This clavipectoral fascia, name itself.
All right, clavipectoral face shield. Takes a quick YouTube or Google search to find out how to correctly pronounce these. I'm about 90–95% on the pronunciations, but every once in a while I do have to go to YouTube to find out the pronunciation. All right, so make sure you know that clavipectoral triangle, but let's keep moving because here's the pectoralis major box for you. And if we're looking at origins, we're looking at insertions. Well, first off, easy enough, the insertion is on the intertubercle sulcus of the humerus. Not so easy is the origin, which actually has the clavicular part and then a sternocostal part. We said the two heads. Make sure you know the two heads differently. So really you could separate it from the medial one half of the clavicle. That's the clavicular head, clavicle, clavicular, sternocostal, sternum, and then the costal cartilages. So use those things to your advantage. Now, when we're talking about the action of the pec major, glenohumeral adduction. So that's bringing it down, but there's also horizontal adduction. This is a new one for you. This is coming straight across. Let me get my box big here, facing the camera. If I start here, horizontal adduction, like that. Starts here, coming across. If you do this a couple times, squeeze the chest muscles together, you'll feel the pectoralis major contract when you do horizontal adduction. And there's also a little bit of internal rotation in there. Check out this video down here. This is from one of my favorite YouTubers. And this guy is a PT, he's a physical therapist, but he is into weightlifting, and oftentimes he will show specific things for specific fibers and great exercises. He's notorious for taking a marker, and sometimes he's shirtless, but he will draw the fiber direction on his own body and then do the exercise so that you can see how you follow the fibers to focus in on a certain section of that muscle. So check that out. But also, power of three. If there's three heads, or not three heads, Ian, there's three divisions, two heads, three divisions, then there's got to be three different stretches, three different exercises to strengthen it. So let's take a look at those. Here we can see the different divisions. We're back with Arnold Schwarzenegger, upper, middle, lower. Oftentimes, a lot of exercises like a push-up or a bench press will hit the middle, but don't forget about the upper and the lower. And down here, another reminder to follow the fibers. We can see the upper fibers are traveling like that. The middle fibers are traveling across. The lower fibers are traveling upward like that. All right, little game here with the pectoralis major. You tell me which of these three exercises hits which divisions, upper, middle, lower, pectoralis major. And I also want to mention that any one of these exercises will contract the entire muscle. You cannot totally negate part of a muscle if it's one muscle, such as the pectoralis major or the traps, but you can focus it in on a certain fibers. So we're not turning off certain parts of the muscle. The whole muscle is contracting, but focusing on different fibers of that muscle is what we're doing here. So in our professional teams, we will talk about which one of these pictures does which fiber orientation. And I do have one slide on the breast tissue, since we're talking about the pectoralis major and the breast is in the pectoral region. This is a slide just demonstrating the different anatomy of the breast tissue, looking at things such as the pectoral fat pad, the lobes of the mammary gland, the lactiferous duct and sinus, producing the milk that a female would produce, specifically post-pregnancy, as well as the areola and the nipple. So just be familiar with the general anatomy of the breast tissue as it relates to this region of the body. But done with pec major. Can't forget, if there's a major, there's probably a minor. And in this case, there's a pectoralis minor muscle. This one's deep to the pec major. Remove the pec major, and now you can see the choroid process. Choroid process as the insertion, and then ribs 3, 4, 5 as the origin. So ribs 3, 4, 5, origin, insertion up here. This one's going to stabilize the scapula and raise up the rib cage during inspiration. So when you breathe in, take a breath, real deep breath at home, you'll feel that rib cage elevate. And when you do that, know that it's this pectoralis major elevating, one of the muscles elevating the rib cage. Speaking of elevation, a muscle that elevates the scapula is the levator scapulae. This one's posterior. We're in the cervical region. We're going from the transverse processes of C1 to C4 down to the medial border / superior angle of the scapula. So this muscle is going to lift on up the scapula, as well as some downward rotation. Start a list, grab a piece of paper if you're not taking hand notes, or on your computer, and start a list of muscles that do downward rotation. Let's move on over to the shoulder, and the shoulder has the deltoid. So the deltoid is coming down here and around, huge shoulder muscle. Shoulder pad muscle is what they call it sometimes. Some legends of bodybuilding on the screen right here. We can also map out things like the pectoralis major. The traps, if they get large enough, since part of the insertion is on the anterior lateral 1/3 of the clavicle, the traps will come over top of the back and protrude anteriorly. So notice these are the traps right here, but we're on the deltoid, so let's stay in the deltoid. What? Another power of 3. We've got 3 different heads of the deltoid. Here are the 3 heads of the deltoid. We've got let's start with the anterior clavicular head. We've got the middle or acromial head, and then we've got the deltoid and the posterior spinal head as well. I'll let you read through all these different origins and insertions. The key one to note is that they all insert on the deltoid tuberosity. They all insert down there, but they do have different actions for each one of these heads. So let's talk about different exercises. This is actually Mr. Athlete X right here, and he's drawn on the different fiber directions of the muscle. But down here you can see various exercises. Let's go through this example because this is a good example to show you what's going on. Let's say this picture right here of this woman doing some shoulder raises. Now that's most in line with the middle fibers, because if you take your arm straight out, it's going to go straight down. That's the middle fibers that we can see right here. Middle fibers action would be shoulder abduction. Shoulder abduction. Now, let's look at this other one. If we look at the anterior fibers, anterior clavicular fibers here, I'm going to draw these on down here. Now it's tough to see, small picture, but really that's abduction and bringing it anteriorly. So horizontal adduction and a little bit of internal rotation. She is internally rotating her hands to work that anterior head of the pec, or of the deltoid. And finally, the posterior fibers. Here they are back here. Basically what she's doing is she is starting in the up position, and now she's doing horizontal abduction. If you do this at home, you'll start to feel the posterior heads of the deltoid. 3 different exercises for technically the same muscle, but they've got 3 heads, so they are different actions. All right, just a couple more videos to cover in this PowerPoint, so stick with me because we're on to the rhomboid minor and the rhomboid major. There's a major, there's a minor. And let's take a look at these here. Down here we can see the minor is this smaller section. Let's go MI for minor, and then major, we're going to go MA, looking at this larger part right here. Now, the dividing line is typically this spine of the scapula. But if you look here, the minor has its own origin, the major has its own origin, and they have different insertions as well. Minor, more superior. Minor is more superior, and it's typically above the scapular spine. So you can use the scapular spine as a dividing line between the minor and the major. What is this one doing? Mainly scapular retraction, but a little bit of downward rotation. You remember that list? You got levator scapulae. Now you're going to add rhomboids to the downward rotation movements. Take a look at this GIF down here. This GIF is showing scapular retraction, and then when you see the inferior angle turn medially, that's the downward rotation. So I'll track it with you here. It's kind of resetting, and then what it's doing is scapular retraction, and then scapular blanking on the name here, scapular retraction and downward rotation. Get it together, Professor Klein. We've got scapular retraction and downward rotation. What's that look like? Well, you could use a TRX band here, and you can start in the protracted position, protracted of the scapula, and then pinch the shoulder blades together, scapular retraction. That's kind of the cue that a lot of personal trainers and physical therapists will give to work the rhomboids. You're kind of saying, well, wouldn't you work the traps as well, the middle traps? That does scapular retraction. Definitely. You would work both of them. My question for you in the professional team meetings is, how would you maybe target the rhomboids? How would you target the trapezius middle fibers and those differences? All right, a muscle that's dear to the heart, and I say dear to the heart because it's very close to the heart of the body, is the serratus anterior. We haven't talked about this one yet, but we are right now. It originates on ribs 1 through 8, 1, 2, blah, 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 to 8 down here, and it inserts on the anterior surface of the scapula. So we're going from the scapula over to the rib cage. What does this one do? It's kind of a funky looking one. It's got these pointed kind of edges to it on the ribs. Primarily, this is going to stabilize or fix the scapula to the rib cage. What does that mean? That means fix or stabilize. It's going to stick the scapula, keep it tight against the rib cage. And I do want you to note there's a primary function and a secondary function. The secondary function is to protract the scapula. but primary is to just hold it in place. The scapula, it likes to come off the rib cage if it's not locked in, and this serratus anterior is going to lock it, stabilize, fix it to the rib cage. A nerve that you definitely will want to know is the long thoracic nerve. I love asking questions about the long thoracic nerve because there's a lot of issues that can occur with that nerve and thus affect the serratus anterior. Here's an OU track and field legend, Dan Bailey, who actually was ranked top 10 for multiple years in CrossFit. So if you follow CrossFit, you might have heard of Dan Bailey. But Dan Bailey has some prominent serratus anterior muscles. Just to show the surface anatomy right here, you can see the different, sometimes they call them wings, traveling on the sides as the serratus anterior. While we're at it, we can hit up the deltoids, we can hit up the pec major, we can hit up that rectus abdominis, external oblique, internal oblique, transverse abdominis deep within there, biceps, triceps. I mean, you should be able to do this when you see a picture of somebody with muscles that they can kind of see through the skin. So be able to do this skill very well. So Professor Klein, what are some of these issues with the long thoracic nerve? Well, one of them is called a winged scapula. A winged scapula can be seen here. It's where the scapula does not fix against the rib cage, which is the primary function of the serratus anterior. Instead, it comes off and you can see a gap of space. You almost can fit your fingers in between the scapula and the rib cage. That's not good for stability. That is definitely not good for stability. They won't also be able to protract at the end of a push-up. And with that being said, I'd like to introduce you to Bob and Brad. They call themselves the most famous PTs or physical therapists on the internet in their opinion. So they've got over, I think, millions of subscribers, and they really just bring the anatomy and the exercises in a very easy to understand way. So let's watch a little bit of their video. All right, let's watch the video from Bob and Brad here.
Hi, folks. I'm Bob Trump, physical therapist. Brad Heineck, physical therapist. Together we are the most famous physical therapists on the internet. You know, kidding, of course, Bob. Brad, today we're talking about, why do my shoulder blades stick out? Not just me, but why maybe some people in the audience. And what are you going to do about it? That's called wigging scapula. We're going to show you 10 exercises and stretches you can do. And by the way, there's really two instances where this may happen. One, it may happen just on one side. Sure. And that's usually an injury or maybe a neurological event. I know because I had it happen to me. Right. On my left side, I got an inflammation in there. They don't know what it was, maybe a virus. Sure. And it affected my long thoracic nerve. Okay. Which affected my serratus anterior, which is a muscle that helps hold the shoulder blade into the wall of the ribs. And just hold on, because we're going to show you a really good example of it. Exactly.
So notice he said long thoracic nerve. He said serratus anterior. He gave the function. You've got to know this anatomy if you want to be a physical therapist for sure. So let's skip on forward to where they start to show what this is.
Here, we provide videos on how to stay healthy, fit, pain-free, and we upload every day. Excellent. All right, now, here we go. This is it. This is like going to one of those circus shows. This is a freak show here. Yeah, freak show. And I'm going to pull this down. All right. So, can you see that? You can see a scapula in there. Now, that's when he's down there together. Now, go up, Bob, once. And see this? I can get my finger down at this scapula right here. It's way out. Yeah. Yep. Can you see that, Lonnie? And then this one here is this bad one, which is not near as far as this one. So I think it gets scarred down. Right. So if you can, that means I can put my whole hand. You're wearing me out here, Brad.
I mean, that's a pronounced wing scapula right there. Those are coming way off the rib cage. Let's jump to where they start to do some exercises to strengthen these things here. They get really creative with what they're doing to make it very easy to do these.
Great way to get a good stretch over the chair. This is an easy one to do. You do some stretches like this. You're stretching the mid back. You're stretching the shoulders. You're stretching the chest. If I wanted to give him a little extra, but the palm is down and he's doing this. Yeah. So I'm going up at the same time. So thumbs toward each other. Now thumbs up. Kind of like you're doing the hitchhiker. Yep. Thumbs towards each other. Now it's thumbs up. Here, just wait, bro. This is driving me nuts. Here, do it like this.
So you can watch the rest of that video later. Check it out. Like I said, they've got over 2 million subscribers. But really, how do you strengthen the serratus anterior? One of the main ways is a push-up plus. So push-up plus is basically doing a push-up plus some. And what we mean by that is protraction. So this would be a normal push-up right here. But if I drew the same line, notice how the back is arched rather than here where it's flat. So that extra push in the up is produced by the serratus anterior. You can also do it hands and knees here. Take a moment. Let's do a push-up plus here. Professor Klein will do it with you. If you get on up out of your chair, come on, get on up and find a nice place on the ground or somewhere. And if you're coming back, you're doing a push-up. So you're coming down, not the best push-up, but up, and then you're pushing that last little bit. So I'm coming down right here, and then protraction up like that. So this is retraction, protraction. And if I even just hold this, if we hold this together for 10, 20, 30 seconds, I trust that you're doing that with me at home. You're gonna feel the serratus anterior contract and hold the scapula in place as you protract. So, kind of out of breath. I got to do that more to stay in better shape. But doing a push-up plus is just one way. You can also take a cable machine and push out. But again, if you stop here, let's say I start here, stop here, that's not protraction. This is protraction. From here to here, here to here. Such a small movement, but that muscle has to do protraction to make sure that it's worked. All right, that was all the muscles of the back and the shoulder and the chest. Well, not all the muscles, what we would maybe call the glamour muscles. And as it says here, you only work out your glamour muscles and you know it if you're a fan of It's Only Sunny in Philadelphia. But we got to do another video because we're out of time for this video. So check part 2 of the shoulder and back muscles for the rest of this PowerPoint.